Hello, welcome everyone to AIDS 2022 and this official pre-conference, including those who are joining us online today. I'm Nitya Panupak, the IAS Governing Council member from the Asia Pacific region and Executive Director at the Institute of HIV Research and Innovation, or IHRI, which is based in Bangkok, Thailand. Today, together with Dr. Wafa El-Sardia, the founder and director of ICAP at Columbia University in New York, we will be sharing this pre-conference. And in line with the AIDS 2022 conference theme, which is re-engage and follow the science, this 3.5-hour pre-conference will spotlight the important role of the differentiated service delivery, or DSD, in supporting HIV treatment continuity and re-engagement in care for people living with HIV who have experienced treatment interruptions. And can I have my the slide on, please? Because we are going to show you that we have no conflicts of interest to declare. And then probably I can move forward so to save the time. And in this pre-conference, we are going to talk about DSD for HIV treatment. The opening presentations here will outline the current state of DSD for HIV treatment in 2022 in terms of the global and country policies, evidence, and implementations. Our speakers here will highlight the critical role that DSD for HIV treatment played in response to addressing COVID-19 challenges. And while we have gained tremendous gains have been made, there are considerable opportunities for DSD to further support the successful service delivery models transitions and improve sustained re-engagement for those who return to care after periods of disengagement. And in the second and third parts of this pre-conference, opportunities for further innovation will be outlined, and our attendees are asked to engage and contribute to shaping a collaborative way forward. And now I will hand over the microphone to my co-chair.
Thank you very much, and it's a pleasure to be here and to welcome people who are here with us today and those who are joining virtually. So I'm Wafa El-Sardia, and I'm going to introduce very briefly our speakers for today, a very eminent group of experts who've joined us for this session. Our first speaker will be Dr. Meg Doherty. She's the director of the Department of Global HIV, Hepatitis, and Sexually Transmitted Infection Programs at the World Health Organization, WHO. And she's had more than 3 decades of experience working in HIV and other infectious diseases, and particularly involving the leadership of WHO's normative and programmatic work that's focused on expanding HIV prevention and treatment around the world. She's very committed through all of her work to reducing the inequities that we know have existed in the global HIV response. And she will present today on resilience and scale of HIV treatment programs during the COVID-19 pandemic. Meg will be followed by a presentation by our next speaker, Dr. Anna Grimsrud. And she's actually the person who pulled us all together here today, so thank you, Anna. And she is the Senior Technical Advisor with IAS. And together with her colleagues, she's convened this pre-conference and worked to pull together the speakers as well as the variety of different sessions and opportunities for conversation. And today she will share with all of us a brief background on DSD and then focus on how COVID-19 has expanded eligibility for DSD around the world. Our third speaker joining us today is Lauren Bailey, who will present on extending ART refills to ensure uninterrupted supply. And she works at USAID and is the multi-month dispensing and differentiated service delivery advisor at USAID's Office of HIV/AIDS in Washington. To be followed by our next speaker is Maureen Milanga, and who works with Health Gap, and she's based in Kenya, who will present on the importance of community-based models of ART delivery. And she's the director of the International Policy and Advocacy with Health Gap, and comes with a very strong background in HIV advocacy over years and years. She's also a member of UNAIDS advisory group, and she will share data today with us on some of her work. Last but not least, we welcome Dr. Tsitsi Apollo from the Ministry of Health and Child Care in Zimbabwe, who will present on DSD for HIV treatment and integration, and highlighting particularly Zimbabwe's efforts and forthcoming update on the on how to integrate a DSD with for HIV treatment with integration with other non-communicable diseases, as well as with contraceptive care, mental health, and issues, and also with tuberculosis. So I think without further ado, I'd like to then invite our first speaker, Dr. Doherty, who's going to give us her presentation.
Thank you very much. And let's see if I can arrange to get the slides up. Very good. And I'm really pleased to be here today. And I was just thinking and reflecting on the fact that it was probably 5 or 6 years ago where we were working, Anna, myself, and a number of other people, about how do we ensure that we can bring care closer, and how do we ensure that all of these models that have happened very organically are actually brought to scale. So I think in many ways, it's pretty impressive to see now we're actually talking about scale, and that we're here talking about DSD for other things other than treatment, but for testing, for prevention, etc. But my mandate today is to talk about resilience, presumably during the time of COVID, but now we have the time of monkeypox and the time of climate, the time of every other disaster that's coming our ways, but also about treatment programs. And what do we see as some of the real, areas of optimism that we can see there? I think the important piece to say is COVID is not over, even though the major part of COVID has happened already in terms of, a lot of the morbidity and mortality, and vaccines are starting to get out. We're still seeing high numbers of cases, new variants, and I think what you can see from below, where we have our highest burden of HIV in sub-Saharan Africa, we have our lowest coverage of vaccination. So in many ways, our programs still have to be thinking and are potentially at risk because of COVID. And we heard yesterday from the new report out that we are stalling, that our HIV response is in danger. We have 1.5 million new infections, which is the same as last year, and 650,000 deaths per year. Again, a stalling. And when you look deeper into what's happening in that stall, it's new countries that have had control who are starting to see new infections occur, and that we're starting to see a slowing of the drop of people getting onto therapy. So something about what we're doing has to change. And if one nugget to say is we have a new infection in young girls and adolescent women, adolescent girls and young women every 2 minutes. And we have 70% of new infections in key populations, so the most vulnerable. So how do we get DSD to the most vulnerable? This slide really just shows that declining, the stagnation, in another way to look at it. It may look like we're on trajectory to reach our goals, but we're really not unless we change what we're doing now. And this here just talks about the fact that where new infections are occurring, and it's either in the key population themselves or their partners. And we have to keep this in mind because so many countries still are not addressing their key population epidemics and ensuring that all of the services are reaching those who need it the most. In terms of cascade, it may look that we're doing pretty well. 85 knowing their status, 88% on treatment, 92% virally suppressed. But when you start to look into the details of our adults versus children, adults are much better off than children, where we still only have coverage of 52% of kids on treatment, 41% of them is virally suppressed. And we have major differences by regions. So this has to be addressed as well through DSD approaches. And we know that some of the disparities are also among men. Often we talk about women needing our guidance, but men are also being left behind on this cascade. So I hope our DSD also can address what men are not doing in terms of being able to get access to treatment, how we haven't yet figured out how to bring services closer to men. Now, going into the disruptions, WHO has had 3 rounds of what we call a pulse survey to look at what are the reporting disruptions in communicable diseases, whether TB, HIV, malaria, hepatitis. And we can see over the time, this is now in Q4, the 3rd version of this. We had thought that there would be fewer disruptions in continuation of treatment. But look, the biggest ones have been around HIV services, testing services, preventing services, but also the initiation of new antiretrovirals was a new factor we put in, has creeped up. And I think this is pertinent to our conversation for today because it's that it's starting and maintaining ART that we're missing out on and that we have to look for. And I think also this perceptions of disruption and recovery for HIV has been relatively good, where some think we're not actually still disrupted, where we, in the red are where we're disrupted. But I think, again, this is just the surface, and this is the perception of ministries of health. We need to actually see what is being delivered. So when you start to look at if testing has not been maintained at the highest level that we would like, and here's some data coming from a country that shows a decline over time with COVID of first ANC testing, or those who are new or naive to ART, they're getting onto therapy. You can actually see that this testing is also, and decrease is also linked to starting and initiating therapy during this period of time. But what is going well for us? We have DSD policies around the world, and as you can see in orange, they're mostly adapted or partially adapted around the world, with some countries fully adopting all of our various DSD recommendations. And we have seen, and I'm sure others will reiterate this in their presentations, that national policies have moved for for expanding or decreasing the frequency of needing to go and pick up drugs. And by WHO regions, in the blue, dark blue, we can see some of the regions are really moving to 6 months pickup or every 3-month pickup. Once a month pickup, we should really not be seeing any longer, so that's something where we can make some effort. And we also have seen that policies have been moving towards, especially in the African region, towards community delivery of antiretrovirals, where we need to do much more work across the world, and also where we can have that happening outside and for all populations, whether they are adults or breastfeeding or children, and really make sure that those policies address those who can be left behind. This I don't need to explain. You've been in this room, and this is the quartile or the 2x2 table that we've seen from Anna for many years. But I think what we want to talk about is it's been a really useful tool. It really helps us with person-centered approach, and we've been looking at it with our updated guidelines to also be thinking about KP and key populations and having more individualized models addressed. And one of the things we did in 2021 is to ensure that the criteria did not exclude people. So it doesn't exclude those who are pregnant, it doesn't exclude those with well-controlled chronic health conditions, and it doesn't include children. And I think making sure that when you're at your settings in countries, that we can see that fully implemented, that there is nobody who is not given this opportunity. And we also have put forward last year some new service delivery recommendations, which we hope will help with the continuity of care. Tracing and supporting people who've disengaged, but in a non-stigmatizing way. Integrating services that people need, whether it be SRH, sexual reproductive health and contraception services, diabetes, hypertension, mental health services. All of these are very important to ensure long-term continuity. Lastly, on the last few slides, I'll talk a little bit about scale up of some of these models during the time of COVID, and I'm sure you've heard about these, but telemedicine has really improved the access to many of PrEP, for example, for self-testing, and you'll hear more about the multi-month dispensing, but many, many examples of where countries weren't doing it before, starting to do it, and doing it for other drugs like opiate substitution therapy or hepatitis treatment. And lastly, we have a whole group now working, and it's really exciting. Waf and I were just discussing who's going to take on this mantle as we go forward. Where is the passion from youth around HIV? Well, I've seen a real passion for young people getting excited about virtual interventions. And I'd have to say they're going to help shape what's going to happen next for either COVID and or for HIV, for monkeypox. And I think some of those rapid initiations of how do you do self-care, how do you test in the home, how do you get support online, how do you have things delivered to your home, how can you also then have that data tracked for your clinician, but in a secure and safe way, so that you can be counted, and also that you can, if there are any warning signs, that a person can have the support they need. So we're just giving some examples that this was done in Nepal, where social media platforms, dating apps, et cetera, for new populations really engaged people to get them into either testing and to have community-based peer champions that could connect with people online on their phone. So my last few slides just speak about the fact we have to monitor what we're doing in DSD. And we have new strategic information guidelines that are coming out tomorrow. And part of it has a whole focus on how to integrate the monitoring of differentiated services within the HIV monitoring system. And there are 5 new indicators. I won't go through them, but I invite you to join us tomorrow during our satellite session on innovations and new recommendations, where you can hear more about what these DSD indicators are. And with this, I'd like to thank you all for inviting me for the overview, and I'll have to forgive myself because I do have to step out to go to another engagement, but thank you very much.
Thank you. Thank you very much, Dr. Doherty. As Dr. Grimsrud is coming up to the podium, just remind everyone who's joining us virtually, you can submit your questions during any of the talks, and also people in the room, I believe you can also submit questions through a QR code, and we'll have the opportunity also for you to ask your questions here in person at the very end of all of the presentations. Go ahead, Anna.
Great. Thank you, everyone. So hello again, and welcome to Canada, my home country, and to those of us joining online, welcome as well. I'm going to share with you a brief presentation on DSD before COVID, and then speak to how eligibility was expanded in response to COVID-19. I have no relevant disclosures. So in 2016, the first definition of DSD was published, and this outlined how DSD is person-centered and both simplifies services for people living with or at risk of acquiring HIV, while also reducing unnecessary burdens on the health system. In this pre-conference, we're going to focus almost exclusively on DSD for HIV treatment, but DSD applies across the continuum of HIV services, from prevention through to viral suppression, and can also be applied to other health conditions. In 2015, we had just seen the first global public health target met ahead of schedule, with 15 million people receiving treatment by the middle of the year, 6 months before our own deadline. This success was attributed to the meaningful engagement of communities affected by HIV and the simplification of HIV treatment with a one-size-fits-all approach. As part of WHO's 2016 update, a new chapter was added on service delivery. And this was a big deal and represented a shift, with WHO acknowledging the diverse needs of people living with HIV and endorsing a differentiated care approach, with recommendations made on task sharing and decentralization, and this marked shift away from the one-size-fits-all approach of providing HIV treatment services. This guidance also outlined the building blocks that Meg also showed: the when, or the frequency of visits, the where, or the location of services, the who, or the cadre of staff providing services, and the what, the package of services. Over time, and following WHO's lead, more and more countries have defined these building blocks separately for clinical consultations, and then separately for ART refills, as well as for psychosocial support as required. In other words, by the end of 2019, many high-burden HIV countries were well on their way to providing DSD for HIV treatment. And then COVID happened, right? And in March 2022 and the weeks thereafter, national ministries of health, global normative agencies, and funders published guidance on how to ensure uninterrupted access to antiretroviral therapy, especially during periods of COVID-19 movement restrictions. This emergency guidance extended policies in countries, favoring interventions to reduce visits to healthcare facilities and ensuring that people could access their chronic medications. The adaptations to who was eligible for DSD for HIV treatment models can be put into 4 buckets. So first, in orange, eligibility was expanded, and I'll focus more on that in the coming slides. Secondly, in light blue, multi-month dispensing, or MMD, or longer ART refills were provided, and this will be the focus of Lauren's presentation. Also in that light blue bucket is the reality that some countries extended the frequency of clinical consultations. Third, community-based models were emphasized, and this is what Maureen will speak about. And then finally, there were instances where alignment of other chronic medications, such as TB preventive therapy, hypertension and diabetes medicines, and family planning commodities were also provided alongside HIV medications, and this is what Dr. Apollo will speak to. So in terms of expanding eligibility, COVID-19 promoted a more liberal definition of stable or established on ART. The time from ART initiation was reduced, and many countries reduced the need for a recent suppressed or multiple recently suppressed viral loads to be eligible. And eligibility was expanded to more populations and became more inclusive. So as Meg mentioned, it became possible for those with chronic comorbidities, as well as populations such as those who are pregnant or breastfeeding, members of key populations, children and adolescents to access DSD for HIV treatment models. In a series of policy dashboards that we published, we looked at national policies for different components of DSD and the policies during COVID. So in blue, you'll see that national policies were looking at 6 or 12 months on ART before eligibility. And then with COVID, in the orange ovals, you'll see that many countries allowed people to have multi-month dispensing immediately from ART initiation to support having pills on hand. We see examples from implementing partners, such as here in Mozambique, where the time to 3-month dispensing was reduced and the requirement of having a suppressed viral load or evidence of a rising CD4 cell count was removed during COVID. And as a result, there was an increase of 40%, so from 38% to 79% of their cohort having access to 3-month dispensing from the end of 2019 to the end of 2021. In Ethiopia, we saw that women in PMT-CT programs had an increased access as well to multi-month dispensing, from 68% to 92% between May and October of 2020. And in South Africa, there were specific provisions put in place for ART prescriptions to be extended from 6 months to 12 months, thereby making clinical consultations annual or once a year. And as a result, more than 1.5 million people living with HIV, including 200,000 living with HIV and another chronic condition, were able to collect 2 or 3 monthly refills from a health facility, a community pickup point, or a private pharmacy, and then have just an annual clinical visit at the health facility. Earlier this year, the systematic reviews used to inform the 2021 WHO update were published. On the question of the frequency of clinical visits, the authors found comparable outcomes among those with 6 or 12 monthly clinical consultations compared to those with 3 monthly clinical consultations. The current WHO recommendation is for 3 to 6 monthly clinical consultations for those established on ART, with a preference for 6 monthly. And based on this review, and hopefully with more data from South Africa on their experience, we're well on our way towards a recommendation for annual clinical visits for those who are established on treatment. Here is the dashboard for frequency of clinical consultations, and you'll see that many countries are in the middle with 6 monthly clinical consultations, and then a few with annual visits allowed, including South Africa with its orange COVID oval on the far side. For more on the future of DSD research and recent evidence to address and highlight these research gaps, we hope you'll join us on this satellite on Monday morning, The Science of DSD, Where We Are and Where We're Going. Now, while I did say the focus of this pre-conference was on DSD for HIV treatment, I want to take a quick moment and acknowledge the tremendous progress made towards scaling up PrEP in recent years. As a result of COVID, PrEP was differentiated, with reduced frequency of PrEP follow-ups, longer PrEP refills, decentralization, task sharing to peers, and more self-sampling and self-testing. And the number of people initiated on PrEP increased dramatically, with more people starting PrEP in 2021 than in the 5 previous years combined. So if you want to learn more about differentiated PrEP, then please diarize this satellite on Saturday morning, where the WHO will launch a technical brief on differentiated and simplified PrEP, and we'll share some key considerations for countries as they're developing their PrEP guidance. As mentioned by Meg as well, COVID nudged us towards virtual interventions, including those to provide support, to accelerate initiation, and to facilitate monitoring. And in a special issue of the Journal of the International AIDS Society, this paper from Nataya's group in Thailand showed how telehealth enabled same-day ART initiation. And to paraphrase a quote from one of their clinicians, we needed to find a way for clients to get their treatment and receive medical services as if they came to the clinic. We chose technological tools to make this happen. DSD is and has always been part of this journey towards self-care, and while ensuring that this isn't done as a way to obfuscate the responsibilities of the healthcare system, and this trend was also accelerated during COVID with self-testing for HIV, self-sampling for STIs, self-management of chronic conditions, and increased self-monitoring. So now in 2021, WHO guidance has taken on many of these lessons, with guidance on ART initiation outside of health facilities, recommendations to support re-engagement, and making 6 monthly clinical and clinical visits and ART refills preferable. And this is great, but we can also go further together. So we hope all of you in your respective roles can continue to publish and share lessons from COVID-19, such as the outcomes with earlier access to multi-month dispensing for those with elevated viral loads, outcomes among key populations, and the impact of annual clinical consultations. So in closing, we have to grow through what we go through, and it's critical that we retain many of these adaptations that were put in place 2 years ago. We hope that countries and all of us will learn from the recipients of care and the importance of supporting community systems as we continue to collectively accelerate the implementation of DSD for HIV treatment. Thank you.
Thank you very much. And we'll move ahead with our third speaker. Welcome, Lauren.
Good morning, everyone. My name is Lauren Bailey, and I will be presenting on extending ART refills to ensure uninterrupted supply. And I have no conflicts of interest to disclose. PEPFAR promotes DSD in its country operational planning guidance as a person-centered approach to HIV care and treatment that tailors services to different groups of people living with HIV, depending on their evolving needs, while being simple, standardized, and evidence-based. PEPFAR implements DSD of ART across the 4 WHO categories, including client-managed groups, facility-based individual models, out-of-facility community and individual models, and health worker-managed groups. And we promote broad inclusion so that all people living with HIV, including children and families, adolescents and youth, pregnant and breastfeeding women, individuals with advanced disease, key populations, migrant and mobile populations, and clients who are not yet established on ART have access to DSD of ART services. And underpinning PEPFAR's approach of broad inclusion is the idea that we should be separating clinical visits from ART dispensing, and that all people living with HIV ages 2 and up should be eligible for and receiving MMD of ART. PEPFAR recognized the important role DSD could play during the COVID-19 response and released technical guidance stating, the critical intervention for all programs and individuals is to accelerate and complete scale-up of 3 to 6 MMD of ART and decentralized drug distribution for all people living with HIV, including pregnant and breastfeeding women and children. PEPFAR and its partners mobilized quickly to support rapid expansion of MMD and DDD to help decongest health facilities, mitigate exposure to COVID-19, and support the uninterrupted provision of ART. And we did this by preparing the ARV supply chain, supporting facility-level implementation planning, including health worker trainings and identification of eligible clients, and conducting client and community engagement. Starting in March 2020, PEPFAR conducted a desk review of COVID-19 adaptations to MMD policy, largely pulling from government and Ministry of Health circulars. This desk review built off our prior MMD landscape analysis, which cataloged MMD policy and practice in all PEPFAR-supported countries. The table on the right demonstrates a snapshot of the country-level analysis from our desk review, where we compared pre-COVID-19 MMD policy and practice to COVID-19 MMD policy. And we focused on 2 categories: changes to dispensing intervals and changes to eligibility criteria. And we found that 63% of PEPFAR-supported countries with a treatment program amended DSD policy or intensified rollout of multi-month dispensing in response to COVID-19. During the COVID-19 response, as we've recently heard, country-specific MMD eligibility criteria expanded to include populations previously not included under the 2016 WHO definition of stable on ART. These policy changes expanded MMD eligibility to clients who are new to ART, those who are virologically non-suppressed, those with comorbidities, children and adolescents, pregnant and breastfeeding women, clients with advanced disease, and those on second and third line regimens. And clients also became eligible for longer dispensing intervals, particularly 6-MMD. This enabling policy environment helped lead to an accelerated uptake of MMD across 21 PEPFAR-supported countries. And we can see in the April to June 2020 quarter, when COVID-19 adaptations were implemented, MMD, particularly 6-MMD, rapidly accelerated. PEPFAR has been able to grow and sustain high rates of MMD coverage, and by the fourth quarter of 2021, 80% of all ART clients in these 21 countries were receiving at least 3-month dispensing, 36% of which are on 6-month dispensing. We also see accelerated uptake of MMD among children and adolescents less than 15 years of age. As of the last quarter of 2021, 60% of pediatric ART clients are receiving at least 3-month dispensing, of which 13% are receiving 6-MMD. We've also seen a gradual shift toward longer dispensing intervals in the last 2 years. These two graphs demonstrate the proportion of ART clients on 3-MMD versus 6-MMD in PEPFAR-supported countries across a 2-year period. And the size of the bubble represents the size of the treatment cohort. On the x-axis, we have plotted 3 to 5 MMD coverage, and on the y-axis, 6-MMD coverage. And we also have lines bisecting the square indicating equal proportions 3 to 5 and 6-MMD coverage, and 100% MMD coverage. We see that in the October to December 2019 period, most countries were clustered in the low 6-MMD and 3 to 5 MMD less than 50% range. But as of December 2021, we see this migration of countries toward the upper left quadrant, indicating a higher proportion of clients receiving 6-MMD than 3 to 5 MMD, and several countries bordering the 100% MMD coverage line. And we have also seen that as we have scaled multi-month dispensing, there has been no subsequent drop-off or decline in viral load suppression rates. I also want to note that viral load testing was not impacted by the pandemic, but we are not sure if the maintenance of good viral load suppression rates is related to the TLD rollout or other factors. We were able to demonstrate, however, that MMD was positively correlated with improved virologic suppression in a number of countries with high MMD reporting completeness, and these data will be shared during our poster presentation on Sunday. But the 5 countries listed above all had MMD reporting completeness greater than 80%, and we compared the proportion of ART clients receiving at least 3-month dispensing of ART to viral load suppression rates using a regression model that incorporated a 6-month lag between MMD coverage and viral load suppression data to account for time between MMD initiation and subsequent viral load testing. And we can see the correlation coefficients indicating strong relationships between MMD and viral load suppression in these countries. We also have tools and metrics in place for evaluating the quality of DSD service provision. The Site Improvement Through Monitoring System, known as SIMS, is a quality assurance methodology to increase the impact of PEPFAR programs through standardized monitoring of the quality of services at the site level. SIMS currently has 4 core essential elements for monitoring MMD across different subpopulations, including adults, children, key populations, and pregnant and breastfeeding women. SIMS version 4.2, which will be released later this year, will expand the DSD assessment to address availability of different DSD of ART models, integration of DSD with other services, provision of family-centered DSD, batching of MMD with viral load suppression, and the provision of treatment literacy and psychosocial support. The visuals on the right demonstrate the CEE scored, in this case, the 4 CEEs related to MMD, and the number of times the CEEs were scored and the actual score received. And we also have trend data to monitor progress over time. It is worth noting that SIMS visits were largely suspended during the COVID-19 response in a number of countries, but they are starting to pick up again. And we are hopeful that with the release of SIMS version 4.2, we will be able to incorporate more nuanced DSD data into our program. And finally, what's next for DSD and PEPFAR? PEPFAR wants to ensure that DSD is truly person-centered, inclusive, and meeting the needs and expectations of clients. And we aim to do this by meeting client needs through eliciting client preferences for DSD, assessing client satisfaction, and providing case management and virtual support to clients in simplified DSD models. We also strive to optimize MMD by aligning MMD across household members and taking a family-centered approach to clinical appointments and ART pickups, and also batching MMD with viral load testing at both the facility and the community level to further streamline services. And finally, we're looking at ways to better integrate MMD of ART with other services and commodities distribution to facilitate more holistic, person-centered care. Thank you very much.
Thank you very much. Appreciate your presentation. I remind our audience to please feel free to submit your questions virtually or otherwise from people who are attending here. Let's move on to Maureen. Welcome, Maureen.
Thank you. So good morning. My name is Maureen Milanga. I work for HealthGap. I am going to be making this presentation on behalf of myself and Lottie Rata, who was actually supposed to be here to make the presentation but wasn't able to arrive on time. She'll be coming a few days later, but she sends her regards. So my presentation will be on the importance of community-based models of ART service delivery. So I'll be touching a bit on the basics of DSD, some specific examples, and some specific examples from South Africa as well. Yeah, so I'd like to declare that I have no conflict of interest. Yes, so what are community models? So for us, community models are easier, quicker ways for people to collect ARVs. Ideally, having ARVs be brought closer to people, where people live and where people work, and also integrating ARV collection together with TB collection and making it easier for people not to have to go to the facility multiple times, and also having the option of treatment literacy and peer support. So as shared by Meg earlier, there are 4 models of DSD for HIV treatment endorsed by WHO. So there are group models. One of them is the healthcare worker managed group that is facilitated by a healthcare worker or a lay provider. And then we have the client managed groups that are managed by people living with HIV. And then we have the individual groups that are facility-based individual ones, like Fast Track, where you come in, you go quickly, you pick up your medication, you go to work. And then you have the community ones, like the external pickup points. So in various countries, they are known with multiple names, but there are quite a number of out-of-facility different models that have different names. So you have from community delivery, private pharmacy, out-of-facility model, community models. You have drop-in center models. You have mobile outreach models. So there are quite a number. And people living with HIV should access whichever options that they require. So on multi-month dispensing, 6-MMD dispensing is preferred, but there are requirements that bar people living with HIV from accessing 6-MMD. So you can see things like ability to be virally suppressed, new individuals on ART, not necessarily having access to 6-MMD, certain populations like pregnant women, not necessarily having access to 6-MMD. We, in essence, think that 6-MMD is essential and supports DSD, but it's not necessarily essential to doing DSD. It's part of the DSD work. You can use it in conjunction with other models for community models of DSD. Yes, so why are community models important? We've seen in many of our facilities, a lot of them are stretched. There's people face very long distances to get to the facility. It costs a lot of money. So community models are really important because they bring those services closer to people living with HIV. We also see people taking less trips to the facility, so they're able to go to work and spend a lot of time doing other things as well. So community models also offer that option, a really good option for people living with HIV in that space. And then we can see our programs also evolving. So our programs are offering medication for longer. So we need to have community models where we can deliver some of those services easier to people. And even now with new pandemics like COVID, the importance of community models of DSD have become even more important. And I'll touch more on that in the next slide. So in terms of importance of community models during COVID-19, we saw a lot of our facilities, a lot of lockdowns with limited access to facilities for people living with HIV. We saw a lot of clinic closures and staff shortages because a bunch of our staff got COVID and there were very few. Then we saw healthcare users having a lot of fears going to the facility. And others were denied access due to lack of masks, and there were sometimes no waivers for people to access the facilities. And so community models actually really provided a good option for people who are not necessarily able to go to those facilities and access treatment easily. So in terms of policy versus implementation, we can see a lot of countries actually have policies on DSD. But normally, like, the challenge with our countries is that we have policies, but the question is whether we're actually implementing them. And so a ton of our countries, while they have policies on DSD, they're not necessarily implementing them. And we need to see faster implementation of those community models so that we are able to bring those services closer to people. So then in the example of South Africa, South Africa calls their DSD models the repeat prescription collection strategies, and they have 3. So the first one is the facility pickup point, where you go to the facility, you pick up your medicines. And then the second one is the facility adherence club, and then the community adherence club. So at the facility, in the adherence clubs, you get to pick up your medication, you get a bit of clinical support, and you get peer support. And then you have the external pickup points, like the pillet boxes and the post office, where you go there and you collect your medication. So when this slide shows the shift in how people used community-based models during COVID-19 in South Africa. And in the blue line, you can see an increase in the number of people who used an external pickup point. Actually, it was a 50% increase. From 1 million to about 1.6 million people ended up using an external pickup point. So it was a really big increase in the number of people who were using it. And then we can see in the purple line in the middle, that remaining mostly the same. That's the facility pickup points. And then in the line, the line at the bottom, the red one, you can see the adherence clubs, where those declined, primarily because people were not able to go to the facility anymore, and they were not able to get some of the services that they needed in an adherence club. Actually, we think that this line should actually be lower, because primarily, even where the adherence groups were actually in place, they mostly were just acting as an external pickup point, because there wasn't the capacity to actually congregate. So we have, here we see data showing high satisfaction with community pickup points. It's data that is collected by our comrades in South Africa through the Richidze program, which is the South Africa's community-led monitoring program, led by TAC and other partners. So here, of the people interviewed by Richidze between April and May of 2022, about 2,699 people using the facility pickup points were interviewed, and 82% were either satisfied or very satisfied with the community pickup points. And of 1,936 interviewed who used an external pickup point, 91% were satisfied or very satisfied with the services that they were receiving. So we also collected data through Richidze on from asking people living with HIV if they would like to collect ARVs closer to home. And of 9,847 people that we interviewed, 43% said that they would prefer to collect closer to home. And another 40% we interviewed responded that they already collected their ARVs closer to home, which really points to the fact that there's a lot of people who either want or are already collecting ARVs closer to their homes. So for us, of the 43% of people who still wish to collect ARVs closer to home but don't have the access to the services, for us it's an advocacy point to make sure that we are able to provide services closer to people. In my last slide, community DSD does have its challenges as well, and one of them is that it's yet to be fully scaled up. There's a lot of confusion between DSD and 6-MMD. We think MMD is an important part of differentiated service delivery, but should not be equated with differentiated service delivery. We would like to see DSD that is attached to, not only attached to the HIV program, but also touches the TB program, so that we don't make people not come to the facility for HIV service delivery. We've differentiated that, and then they have to come to the facility again for TB medication and things. We also would love to see a return of group formats like adherence clubs that were shut down during COVID and haven't necessarily picked up yet. And we'd also like to see some of these community models funded more so that we are able to bring those services closer to people. Thanks.
Thank you very much. Superb. Yes, please, Titi. And again, remind everyone to please submit your questions for the discussion period. Thank you.
Good morning, everyone. Thank you to IAS for inviting me to make this presentation. I'm Tsitsi Apollo from the Ministry of Health and Child Care, Zimbabwe. My topic is integrating non-HIV services within DSD for HIV treatment in Zimbabwe. I have no relevant disclosures. So providing person-centered care, it means that HIV services should look into integrating with other health needs into the DSD for HIV treatment models. And these are the priority areas for integration into DSD, including TB treatment and prevention, family planning services, cervical cancer screening and treatment according to national guidance, cardiovascular risk assessment and management of hypertension and diabetes, and screening and management for depression, anxiety, as well as substance abuse. So the goal of integration should really be to provide one-stop services for recipients of care during their routine care. And this means that services are offered at the same facility, ideally in the same clinic room on the same day by the same healthcare provider. So HIV treatment models can be leveraged to screen and to assess other health conditions that recipients of care present with when they enter into DSD models and also during their clinical consultation visits. And to integrate the delivery of other medications also into HIV treatment models for recipients of care that are established on treatment. So we do have operational and service delivery manual that we've recently updated, and there are opportunities that exist to integrate other health needs into DSD for HIV treatment models. At the point of entry into DSD model, we would like to integrate screening for TPT, family planning needs, depression and anxiety, cardiovascular risk assessment, cervical cancer, and also continue chronic disease refills if controlled. But also at the point of at-refill visits when clients come to the facility to collect their medications. We'd like to integrate with other medications for chronic conditions, offer TPT, family planning commodities, and other medications for chronic diseases. But when they also come for their annual clinical visits, we also want to integrate with screening for TB, family planning, needs assessment, depression and anxiety. We have a tool that we use to screen and other medical conditions. So it has to be an integrated clinical consultation. So what are the policy enablers in Zimbabwe? There's been a move towards increasing the duration of refills and alignment of medication refills with ART refills. And this also includes revamping our supply chain management system that can support commodity security. Task sharing of prescribing for initiation and maintenance of patients has also been supported, and decentralization of drug dispensing and distribution to the lowest level of care, where the majority of recipients of care, over 80%, receive their services. So what has been our experience in terms of TPT integration into DSD for HIV treatment? Our previous guidance in 2017, I would like to share what was there before and what's there now. So TB screening was already task shifted to lay cadres. For example, the CAG leaders, these are community ART refill groups, their leaders were able to screen patients for TB in the community, and it's documented. TPT is given within CAGs and in other DSD models. In 2021, we did a review of DSD program, and we observed that at least about 16% of over 4,500 recipients of care were already receiving TPT while enrolled within their DSD models. And multi-month dispensing is currently ongoing nationally for 3-HP and 6 isoniazid, 6 months of isoniazid for recipients of care, both those enrolled for both those clients enrolled into the DSD and those that are not within DSD. And during the COVID-19 era, when COVID struck us, we had to issue a rapid guidance for HIV service delivery, and this was really meant to ensure that our services are sustained. And this involved giving people, recipients of care, those already on TB and TPT regimens, we had to keep remaining medicines within the facilities to ensure that they get full course of treatment. So I'm going to use this building blocks, this famous building blocks framework, to really explain what we're doing currently. But this is just to summarize that we've made adaptations to these building blocks, looking at the various TPT services, and the aim is really to integrate TPT into any of the 4 standard DSD for HIV treatment models. And including children and adolescents, they can also benefit from these models. Moving on to NCDs, before, in 2017, all people living with HIV were able, our guidance was such that they will receive an annual blood pressure check as well as cardiovascular risk assessment. And we also synchronized refill dates for ART and other chronic conditions. And we prioritized older individuals and patients with comorbidities. So in the current guidance, we've also looked further. We've defined the specific criteria for defining the recipients of care established on treatment for hypertension and diabetes mellitus, and medication refills are being synchronized and provided for them. And we recognize the opportunity for future of the WHO recommendation of once established on treatment, BP can be checked every 6 months to further simplify service delivery. As far as mental health integration is concerned, we've recently developed a step care pathway flowchart to help health workers screen and manage common mental disorders, which are really becoming common among people living with HIV. So we have tools that are in place to assess for anxiety as well as depression and follow through the care pathway to really to identify the red flags and provide care accordingly. We've also have some guidance for contraceptive care integration within DSD models. And you can see that family planning is offered for women of childbearing age through various refill models. And we recognize that these services need to be provided as a one-stop service. And adolescents should also receive these services in a non-judgmental way. So this is just the building blocks that illustrate different contraceptive devices and how we're offering them, the when, where, who, and what. And you can actually see that We've also introduced, we're piloting a particular type of contraceptive device, the Cyanopress, which is a subcutaneous injectable contraceptive, which provide opportunities for health community cadres and even recipients of care to actually administer contraceptives themselves. So we hope that this will be able to roll this out. Family planning may be integrated using these building blocks into the different DSD models. So what are the implementation challenges? HIV and TPT integration. Recipients of care have to receive multiple bottles of medicines at home, and some of these have got challenges in terms of storage conditions, ability to store such quantities, and the risk of stigma and accidental disclosures. As far as HIV and family planning is concerned, looking at sometimes it becomes challenging to offer a wide range of family planning methods, especially at the lowest level, at primary care level, where you find long-term contraceptives may not be available, because these are usually offered at hospital level by trained clinicians. So limited options, they sort of limit the provision of one-stop shop kind of services, and that the thrust around client-centered care at that level. As far as HIV and NCDs are concerned, we do have issues of staff shortages and limited skills to offer services across the multiple disease programs. So we always have to build capacity and mentorship and all that, and ensure that these staff are equipped to offer a wide range of services. Our tools for M&E also need to be harmonized for them to be able to collect data across the various disease programs. We have opportunities such as the electronic medical record system that has multiple modules across different diseases, and that could be an opportunity for us to be able to record useful data to inform our programs. I would like to acknowledge Ministry of Health, the various technical working groups, and the supporting partners and the recipients of care for their effort and participation in these programs. I thank you.
Thank you. Thank you very much, and thanks to all the speakers for wonderful talks. And again, encourage people who are in the room. We've received several questions online, but those who are in the room to please come up to the microphones and ask your questions. I'm going to start with a question, actually, maybe starting with you, Tsitsi, since you just finished speaking. One concern, one of the questions we have is regarding the costs of NCD diagnosis and treatment, which have arisen as an impediment to the integration of kind of NCD care with HIV care. Just would you briefly address how you're attempting to tackle that challenge?
Thank you very much, Wafa, for that question. So indeed, we've observed that HIV services and commodities are well funded compared to other programs. So recently, we've had various technical working groups that we've sort of resuscitated, including HIV and NCDs, HIV and mental health, to really look at specific challenges and needs. We also conducted a needs of that data, that report. It really helped us to bring to the fore the gaps that exist in mental health commodities. And so there is an discussions to really resource mobilize for mental health commodities and supply chain management and M&E for mental health. And also we are working with the NCD department to ensure that, to support the glycated hemoglobin test is not readily available for us to be able to assess patients that are established on diabetes. So that becomes a challenge. So we are trying to resource mobilize for that.
Thank you very much. To a question for you, Lauren, which regarding the efforts, is PEPFAR thinking, another question from the audience, is PEPFAR thinking up. And the second question is measurement of client satisfaction. How can we make that a reality?
Of my oh, there we go. So in response to the first question, we are multi-month dispensing with viral load testing. We've heard that there have been concerns that the scale-up of MMD has possibly contributed to a decline in viral load testing and viral load coverage. We're not able to necessarily substantiate that data. Are still able to receive their viral load testing, and we encourage streamlining these services to further simplify treatment services for our clients. So I know several countries have been looking at ways to operationalize this and ensure that clients are able to either and then in response to your second question about client satisfaction, this is something we're very much encouraging as well. But on the front end, we want to make sure that clients are in the DSD model of their preference. And we know that preferences change over time as clients' needs evolve. So it's really important to routinely reassess if a client is in the DSD model of their choice. So we want to focus on that on the front end. And then, as clients come in for routine care, provide an opportunity for them to provide feedback on their satisfaction with the DSD services they're receiving, to help inform their own individual case management, and to see from an aggregate level how clinics are performing in terms of being able to respond to client needs accordingly.
Thank you. I'll move on to a question for Maureen. A question that came in is, you're advocating certainly that we don't stop at multi-month dispensing, and that there's more to DSD than multi-month dispensing. And one of the comments and the questions is whether we should kind of move to more of accepting the multi-month dispensing as a standard of care rather than differentiated service delivery, as it's become so prevalent. And then, that way we might then emphasize some of these other models. I'm just curious what your thoughts are regarding this suggestion.
Yeah, so in essence, more multi-month dispensing instead of DSD.
No, I'm saying let's call multi-month dispensing now standard, not differentiated service delivery anymore, and
Yes.
and think of the innovations and the DSD being the other models that you are proposing.
Yes, I think that's a good suggestion, because I think most of the time the challenge is that when most countries are now focusing a lot on 6-MMD and MMD as an option and not necessarily focusing on the others, and so having an option where we have both of those is really important.
Thank you. Anna, question for you, and then I'll hand it over to Natalia. Is one of the questioners here is raising the issue whether DSD is kind of demedicalizing, in a way, demedicalizing HIV services overall, and whether that is adding a burden to the recipients of the care themselves.
So it's a great question, and glad to see that there's some engagement online. Absolutely, I think that differentiated service delivery is about demedicalizing parts of the response and about a shift towards self-care. I think the reality is that we want to make sure we're not doing that at the expense of quality provision of healthcare service. And as has been said, we don't want the healthcare system to obfuscate all their responsibility to the level of the individual. So we've got to find a healthy balance there. Thanks.
Thank you. And unfortunately, we don't have any more time, so I'm handing it over to Natalia to close the session.
This is such a wonderful session, rich information, and it has set the stage for the discussions in the following sessions on the opportunities for innovations. And I think that we have heard a lot of what Wafa just mentioned about MMD as part of the standard so that we can move forward for innovations is very, very important. We need to think more about the key populations, DSD. We need to think more about STI integration and all many other things. So thank you very much, everyone, for joining us here today. And we will be back at 10:15 for the second session.